Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan Cloud. Lebih dari 15 kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Kota-kota besar saat video ini sedang memberlakukan pembatasan sosial berskala besar atau PSBB. Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JEC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JEC. Dengan layanan JEC Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang JEC Cloud melalui kontak center JEC di 0804 122 1000, email jecloud@jec.co.id atau WhatsApp JEC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JEC. JEC Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda. Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget, apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda. JSC Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC at Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC at Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC at Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC at Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Very good.
Yeah.
Do you remember?
Yeah.
This is from you.
Thank you, then.
I really love it.
Thank you very much.
JSC at Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC at Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC at Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC at Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id, atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC at Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda. JSC at Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC at Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JEC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JEC. Dengan layanan JEC Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JEC Cloud melalui kontak center JEC di 0804 122 1000, email jecloud@jec.co.id atau WhatsApp JEC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JEC. JEC Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Good afternoon to all participants from Indonesia and abroad. It is a pleasure for us to have you all in this afternoon. Allow me to introduce myself. My name is Dr. Manda from Contact Lens and Dry Eye Service, and I will be your host for today's Contact Lens webinar. Good afternoon to all the respected speakers that are already joining us from GEC Menteng and GEC Kedoya. And also I would like to welcome our distinguished speaker, Professor Shizuka Ko from Osaka University, Osaka, Japan. And I would like also to welcome to all of you to our GEC Contact Lens webinar with a novel theme, which is From Zero to Hero. Today, we will see 5 different topics about contact lens, then that will enlighten our new perspective of contact lens. Ladies and gentlemen, we will begin our webinar shortly. Today's webinar will be divided into 2 sessions. The first session, 5 speakers will present their topic, and after that, we will continue with the second session, which is the Q&A session. Before we start the session, I would like to encourage all the participants to write down their question in the Q&A chat box, and for those who join with YouTube Live, you may write down your question in the live chat. And also, we will greatly appreciate it if you can fill in the polling at the end of the webinar as our continuous improvement. To start our first session, allow me to invite our first speaker, Professor Shizuka Ko from Osaka University Medical School, Osaka, Japan. It is an honor for us to have you here today, Professor Shizuka. Good afternoon, Professor Shizuka.
Good afternoon, everybody. Selamat siang.
Yeah, thank you, Professor Shizuka. Professor Shizuka will present the topic of eye transformation in contact lens user. Allow me to read her profile.
Okay.
Let's go with the profile. Okay, thank you. Professor Shizuka graduated from Osaka University Medical School, Osaka, and Japan. She did fellowship and training in corneal and external disease at Osaka University Hospital, and also research fellowship at Flom Eye Institute at University of Rochester, New York. She is the member of many associations, including American Academy of Ophthalmology, American Society of Cataract and Refractive Surgery, International Society of Refractive Surgery, International Society of Dactyology and Dry Eye, Tear Film and Ocular Surface Society, Japan Ophthalmologist Association, Japan Contact Lens Society, Japan Cornea Society, and Japan Dry Eye Society. Professor Shizuka, you have 15 minutes to present your topic. The time is now yours.
Yes, thank you. So, can you see my presentation now?
Yes.
Okay, great.
Yes, Prof.
Okay, right. So, selamat siang. It is my great honor to see you all give a talk today. Thank you for the kind invitation to such a great seminar. Contact lenses are widely used to correct refractive errors. According to the annual overview of contact lens prescription trends, which surveyed contact lens fits from more than 20,000 cases from 25 countries in 2019, soft contact lenses were prescribed in 87%, while GP are supplied in 13% of fits. Let me explain about CLD. CLD is defined as a condition characterized by episodic or persistent adverse ocular sensations related to lens wear, either with or without visual disturbance, resulting from reduced compatibility between the contact lens and ocular environment, which can lead to decreased wearing time and discontinuation of contact lens wear. The prevalence of CLD and dryness symptoms in soft contact lens wearers is reported to be around 50%. Uneven or insufficient tear distribution and increased friction are two main factors underlying the mechanism of CLD. First, we will focus on tear film. Once a contact lens is placed on the eye, the tear film is divided into the pre-lens tear film and post-lens tear film. Although the pre-lens tear film is less stable and thinner than the tear film over the cornea, post-lens tear film plays an important role in providing a smooth optical surface. Another function of the pre-lens tear film is to provide comfort and lubrication to the palpebral conjunctiva, reducing the friction between the lens and palpebral conjunctiva. The post-lens tear film may be involved in interactions with the ocular surface and affect ocular comfort during contact lens wear. In addition, through tear exchange, the post-lens tear film removes the cellular and inflammatory debris contained within the lens itself. Tear evaporation rates associated with soft contact lens use are high, even if soft contact wearers are asymptomatic. Therefore, patients who previously did not experience symptoms may develop symptoms of discomfort and dryness. For successful contact lens wear, both pre-lens tear film and post-lens tear film are important in maintaining ocular health. A contact lens dry eye questionnaire is the most likely candidate for large-scale CLD assessment. The contact lens dry eye questionnaire 8, CLDEQ8, is reported to represent the most validated measure of these symptoms. This is an 8-item self-administered questionnaire that queries the frequency and related intensity of discomfort, dryness, and blurry vision, and the frequency of closing eyes for relief while wearing contact lens and removal of lenses earlier than planned for relief of symptoms. There have been no validated questionnaire for soft contact wearers in Japan. Recently, we translated and validated Japanese version of CLDQ8. The diagnostic cutoff criteria of less than 12 points for the CLDQ8 were established among English-speaking North American contact lens wearers. In our study, a cutoff score of less than 11 points with the JLCDQ8 related best to patients who reported excellent or very good overall opinion of their lenses. The JLCDQ8 was capable of differentiating of soft contact wearers with different overall opinions of their lenses, comparable to the original CLDQ8 English. Currently, translated version of CLDQ8 is available in Spanish, Japanese, and Turkish. Japanese and Turkish versions of the CLDQ8 are valid, but it is reported that elaboration was required for the Spanish version of CLDQ8. Several tear film changes have been associated with this compartmentalization during contact lens wear. Actually, their influence on comfort remains unproven and inconclusive. We measured non-invasive breakup time with kilogram 5 with and without contact lens. While tear film was very stable with the contact lens, as you see above, tear film stability decreased with the contact lens wear. You can see the many warmer colors which indicated disrupted tear film. And also you can see the decrease of non-invasive breakup time in the right side. We investigated tear meniscus height change with contact lens wear using OCT. Tear meniscus height decreased significantly after wearing contact lens. But particularly decrease of tear meniscus height was greater with high water contact lens compared with low water contact lens. To evaluate corneal or conjunctival epithelial damage, vital staining procedures are simple and useful. Fluorescein staining can be widely applied without special tools or devices. So in the left side, you can see the small pattern of corneal staining. This is actually a characteristic pattern in soft lens dehydration-induced corneal staining. In the right side is a 3-9 o'clock staining observed in RGP contact lens wearers. These two patterns are very characteristic patterns. Here again is the mechanism of contact lens discomfort. The conjunctiva responds in various ways to contact lens wear. A possible increase in friction between the lens and lid wiper or between the lens edge and bulbar conjunctiva should be considered. So bulbar conjunctival staining is associated with CLD, particularly soft contact lens edge-related staining. The palpebral conjunctiva has an important role in controlling the interaction with the ocular surface and lens. Identification of the presence of lid wiper epitheliopathy linked to CLD is important. Just a moment. Okay. So let me explain about LWE, lid wiper epitheliopathy, more. Unfortunately, it is often easily overlooked. It is first introduced. The term lid wiper. Dr. Korb first introduced the term lid wiper to describe the area of the upper eyelid that spreads tear film over the cornea or contact lens. The term lid wiper epitheliopathy referred to the disruption of epithelial cell integrity in this area. But pathophysiology of lid wiper epitheliopathy is thought to involve increased friction between the lid wiper area and the ocular surface of either the cornea or contact lens as a result of inadequate lubrication. Increased staining of the upper lid margin has been reported in contact lens wearers with symptoms of dryness. A recent paper found the higher prevalence of lower LWE in soft contact wearers. It may be caused by the continuous friction of the lower eyelid on the same region of the cornea during blinking. More attention should be paid to the lower eyelid margin. We have to recognize geographical characteristics in Asia. Asian ethnicity is a mostly consistent risk factor for dry eye. Similarly, Asian ethnicity is associated with discomfort and dryness with contact lens wear. The increased use of cosmetic lenses has been reported, particularly in Asian young females. Complications associated with these lenses has been a severe issue as well. Makeup particle floating in the tear film and makeup residue in the eyelid margin are sometimes in female soft contact wearers, which may be trapped by lenses and may disturb vision. Please tell the patient to avoid using hand cream before contact lens wear, as these can contaminate the lens or leave an oily film. Silicone hydrogel contact lenses are more lipophilic than hydrogel lenses. Makeup cleansing oil can deform some silicone hydrogel contact lenses. You can see the remarkable deformation in silicone hydrogel contact lens. Let me share with you lens first. This is very simple educational guidance regarding contact lens usage and widely used in Japan. It should be appropriately provided by contact lens practitioners. Washing your hands first before handling lenses. Put your lens first before applying makeup. Remove lens first before removing makeup. Terima kasih. Thank you very much.
Thank you, Professor Shizuka, for the very interesting presentation. Thank you so much, Professor. Now, we will move to the next speaker, but I would like to remind you all still, all of the question will be answered at the end of the 5 presentation. And our next speaker is Dr. Vidyapati Mangunkusumo from GEC Eye Hospital. Dr. Vidyapati is already known for his expertise in refraction and contact lens practice. Today, he will present the topic of the basic of contact lens, evolution or revolution. Dr. Vidyapati graduated from Faculty of Medicine, Universitas of Indonesia. He did the fellowship in corneal transplantation at Erasmus University Rotterdam. He is the member of Contact Lens Association of Ophthalmologists USA, member of Indonesian Society of Cataract and Refractive Surgery, also the member of European Society of Cataract and Refractive Surgery, and the member of Asia Pacific Association of Cataract and Refractive Surgeon. Dr. Vidyapati, please begin your presentation. The time is now yours.
Yeah. Thank you, Dr. Nilu. Good afternoon, all attendees, and good afternoon, Professor Shizuka, you are very distinguished and well known in our Contact Lens Society. And also thank you for your nice speech. Today I have to present a story, not more a story of the contact lens and its evolution and revolution, as it is written here. Well, the basic concept of contact lens fitting and refraction has developed in such a way far, far from its origin as a refractive, uh, optical refractive design uh, instrument, which in far most developments has made its way to a surface alteration, temporary, and now surface alteration permanently. I begin with the first original idea of contact lens as a refractive material. It was then by Descartes 1637 that he believed that fluid substance could correct the anomalies of the eye in a way that, as you see it in the image, in the illustration, that the column of water or fluid has a ability with its refractive index to overcome and overrule the refractive errors. And at that time, the contact lens was really made, molded to the cornea. And you will see here three kinds of molding materials to make basic mold, yes, main mold to make a contact lens that will match immediately and precisely to the cornea. In the later times, this kind of manufacturing is also made by molding, but as a general precision and regression formulae. The optical model, what we adapted was more of the contact lens itself. But nowadays, the contact lens and the fluid which is strapped behind the contact lens attracted more attention to make a contact lens which is more precise and more friendly to the cornea. And also these two materials, the PMMA itself and the fluid lens, will then overrule all of refractive anomalies and also with the spherical aberrations seen by the cornea. So beside refraction, it also overrides the aberrations. And there, in the next coming years, the fluid was also accepted as a system in the contact lens wear. Whereas the effective power of the contact lens, of the cornea, is then still calculated by the classical ways of vertex distance from power calculations derived from the spectacle lens. But in the coming years, it has come to attention that the liquid or the fluid behind the lens will be more prominent. So the back vertex of the power of the contact lens in air and the effective power of the cornea itself, those two components will play a dominant role on the parameter properties of the fluid lens trapped between the contact lens and the cornea, and this is considered to serve as a refractive media itself. From this point, many developments come to our attention. For illustration, I present to you a case, illustration case of an eye with myopic eye of -7 and cylinder 3, 180 degrees with readings and vertex distance as it is. And for that purpose, the contact lens base curve was chosen flatter than the flattest meridian. Steeper than the flattest meridian. And the calculated power of the contact lens, according to the previous formula, was then -6.5. And with the base curve chosen steeper, the total contact lens power was estimated and decided to become -675. So with this way, a fluid lens behind the contact lens is expected to correct the astigmatism. This was at that time the first attempt to correct astigmatism. Fluid contact lens calculation in this kind of fitting later becomes the major parameter or dominant parameter, and the latest finding of lenticular power and surface alteration attempts of the eye. We can see that in such a way because according to the all research, surface alteration becomes more precise in the way they will be able to correct. And this is the schematic findings. Yeah. We begin with a fluid lens of -25, -2 cylinder. See that with this is against the rule. This fluid lens is as outcome of subtraction of the power of the contact lens, which is 4225, yeah, subtracted with the power of the cornea itself, and leaving a condition astigmatism like this. But we can also calculate it in such a way from the power, back vertex power at corneal plane, which is -9 and -6.5 accordingly to the meridians. And if you just subtract this with the fluid lens, we'll see that you end in the same power of -65, -675 on both meridians. So it is seen that the refraction becomes spherical after the fluid lens interacted here with the astigmatism. The contact lens power is then -65, -6.65, and the base curve is still at 42.25 as selected accordingly, steeper than the flattest meridian, 0.25. This short history leads to more successful research by others, and it has taken years and more years into a surface alteration attempt on the cornea. only base inspired, innovated by the fluid trapped behind the cornea. And now we will know that as the stromal remodeling technique is based on the nice fluid uh, lens properties and noted as a lenticle extraction. And now we can find this in a small incision lenticular extraction technique in which it is configured to be taken out from the stroma, like it is here in this illustration, and the end products are the lenticular pieces. These are pieces of cornea which actually are corresponding to the fluid contact lens as it was uh, in our earlier stages of fitting. Uh, the process itself is uh, really taking of a piece of the cornea and therefore making fashioning a flatter cornea. And now the contact lens fitting itself. The contact lens fitting itself is still on the same platform of guidelines. Yeah. As you see here, has four platforms, 4 stages, and each stage is still the same from year to year, from decades, I think. Only the difference is the material used, yeah, from time to time. It comes better and better, and therefore it has also developed uh, more aggressively, not on the making of the contact lens, but also on flattening attempts of the cornea. We know that the cornea itself has an aspherical basic shape, and it is seen as a part of a conical section. And the latest instruments we have here to measure the asperity is also available on the market. But we don't have to work with these sophisticated instruments. We have to know that our human cornea is a little bit eccentric in its uh, corneal regular center, but as optical media, the cornea is still as a lens and has a wide optical center. For this purpose, we use lenses commonly with an edge lift, which is safe, more safe because we basically we use a bicurve contact lens or even tricurve with transitional zones, but this has to be very neatly fitted and aligned to the center, and that in this case we can still use the fluorescein tests. Although with the topography instruments we can do it and simulate it with computers. But for most of us, we still use the fluorescein test to fit a lens properly, neatly, and centrally. This test is still valid until now, and we better look at the basic results of the fluorescent pattern and choose the right base curve to begin our fitting. So the revolution here is that formerly we have to make a contact lens which fit to the cornea. But now we fashion the cornea to fit the contact lens. This is the basic of my speech today. It's a very big change. We call it a revolution. Yeah, the revolution in the means of change based on technology and knowledge. So the only thing what we will have to do here is to maintain our knowledge, to make it more simple, to make it not dependent on too much sophisticated instrument, but applicable for all of us. So at this short speech, I would like to say that the basic formulas in the bibliography are still very valid to have best visual outcomes in our contact lens surfaces. The key to a success is a good central fitting. And if the fitting is nice, you will have a superb correction and sometimes even better than surgical outcomes regarding the correction of aberration. By the development of more sophisticated imaging and measurement instruments, our contact lens knowledge has led us to sophisticated modern techniques of corneal adjustments and later refractive surgery. Thank you for your attention.
Thank you, Dr. Vidyapati, for the comprehensive presentation about the basic of the contact lens. Due to limited time, now we move to the next speaker. Our third speaker is Dr. Fatima Diah from GEC Chandi Eye Center. Dr. Fatima will present the topic of the RGP, the beginning of the future. She graduated from Department of Ophthalmology, Universitas Diponegoro. She did many courses in phacoemulsification in SNEC, anterior segment surgery in Essasso Milan, Italy, and also LASIK in SNEC. She's the member of Indonesian Medical Association, Asia Cornea Society, and also Indonesian Refraction and Vision Rehabilitation. Dr. Fatima, the time is now yours.
Thank you, Dr. Manda. Let me share my presentation. First of all, I would, sorry. Share screen. Is my presentation already seen, Dr. Manda?
Yes.
Thank you. Good afternoon, Prof. Shizuka, all speakers and all participants. Thank you for having me to joining this contact lens webinar. This is such an honor. Today, my topic is about the RGP, the beginning for the future. I have no financial disclosure. About 50% of adults in the US use glasses or contact lens. Here in Indonesia, the study of rapid assessment of avoidable blindness show that around 0.15% population have a refractive error. But unfortunately, we don't have a data yet about the contact lens prescription. The study of international contact lens prescription in 2018 showed that the use of GP lens are above the 30% and its contents constant and remain used more than 10 years. I will discuss first about the development of rigid gas permeable lens material. For the first polymer commonly available in around 1940 were made from polymethyl metaacrylate or PAMA. This lens we call as a hard lens. But these hard lenses are rigid and not very comfortable. Also don't allow oxygen to pass directly to the cornea, which can be damaging to the eye. Now these PMMA or hard lens are not very popular anymore. And then the next episode is found the cellulose acetate butyrate and silicon acrylates, and the next generation is fluorosilicon acrylate. Around this year, the first rigid gas permeable lens become available, and these are made from the combination of PMMA, silicons, and fluoropolymers. This combination allows oxygen to pass directly through the lens to the eye, which makes the lens more comfortable. And also, these lenses are ideal to correct the pathology or the condition such as corneal astigmatism. Fluorosilicon acrylate itself are composed from the fluoromonomers and siloxyacrylate. These atom or fluorine atoms have advantage to improve surface wettability and then tear stability, also increase oxygen permeability and reducing the incidence of deposit. Before we do the fitting the lens, it is better for us to know and understand about the basic parameter of the contact lens. We can see this from this picture. This is the base curve. The base curve is the curvature of the posterior of the contact lens that will adjacent to the anterior of the cornea. And this is the diameter of the contact lens, is the width of the lens from edge to edge. And this is the optic zone diameter, which is the corneal, the anterior curvature of the lens that gives the power of the lens. And the last parameter that we have to consider is peripheral curve. That is very important to fitting the lens because usually flatter than the radius itself. Besides the development of the material, also there were development in the design. The first design was a spherical design around 1950, and then the complex design as spherical design because the cornea was recognized as more complicated, and then a simple sphere, so that a spherical design was introduced with a peripheral curve design. Now we have reverse geometry design, as I mentioned before, Dr. Vidyapati explanation. And the development of peripheral curve design from the first is single curve design, and then big curve design, three curve, and multi-curve. So the complex elliptical shape of the cornea was more fully understood around 1960, and improvements were made by adding the flatter curve at the peripheral curve of the GP lens. This is the big curve design. This is only one flatter peripheral curve. And then this three curve have a central radius and two peripheral curve. And multi-curve design have a central radius and three or more peripheral curve design. Come into fitting procedure, we have to know the indication of the GP indication fitting, such as irregular or high astigmatism, anisometropia, keratoconus, anterior eye pathologies, and unilateral aphakia. And we have to screen also the contraindications such as infection, allergy to contact lens or care system, dry eye, systemic disease such as diabetes mellitus, and bad hygiene lifestyle. For the fitting, we have at least to choose the 3 parameters such as base curve, diameter, and power. For base curve choose, we can start from the flat K for the initial base curve. The K measurement usually written in millimeter or in dioptry unit. Flat K with smallest in dioptry unit and the bigger or larger in millimeter unit. We can also take the measurement from the auto-keratorefractometry. And for contact lens diameter, we have to measure the horizontal visible iris diameter because these lenses are fit in the cornea, so the lens diameter will smaller or less than horizontal visible iris diameter. And power selection, we call it total power equal to trial power plus overcorrection power. Don't forget to calculate the vertex distance power if overcorrection more than 4 dioptry. We can get the vertex distance power from this formula or from getting the conversion from conversion chart or table. And the fitting procedure itself, the goal is to good vision that doesn't fluctuate with blinking or eye movement, comfort for the entire day, and has a low risk of complication. The fitting is very recommended to get lid attachment. From this picture, we can see the lens is usually aligned with the lower limbus, and the upper limbus is overlap the superior palpebra is overlap the superior limbus and the GP around 1 millimeter. This lid attachment is give the stable and good position of the lens and allows the lens to move with each blink, enhance tear exchange, and decrease lens sensation. After that, we can see the fluorescent pattern test. The most common type of lens fit is apical alignment. Here in the picture show a diffuse fluorescent pattern under the GP lens with the thicker fluorescent pattern at the edge of the lens. Next, I will share about my case presentation. The first case is male, 15 years old, with high myopic and high astigmatism. We can see here from the corneal topography with the raw astigmatism. The BCVA for the right eye is 0.8 and the left eye 0.5. We do the fit with the aspherical GP lens, and there is a improvement in the left eye, become 0.8. And then the second case is also the high myopic eye. The BCVA for the right eye is 0.8 and left eye 0.5. We also do the fitting with our spherical GP lens. Both eye improve significantly and become 1.0 for both eye. And the third is, this is an anisometropy cases. The right eye is normal or ametropic, but the left eye have a high myopic with high astigmatism also. The best corrected with glasses is 0.2. And we fit here with the GP lens, the BCVA is improved much, become 0.6. And the next case, this is a special, I think. This male, 19 years old, come to the clinic and we examine the patient, and we get or see the Munson sign of this from this patient, also the Fox striae from this patient. We suspect it as keratoconic eye, and then we do the screening for keratoconus using the topography, and it is interpreted as clinical keratoconus. We can see from the topography is the apex of the cornea is moved or distorted to inferior. We fit with the GP lens, but with the special design and the very steep base curve. From the right eye, the improvements also good enough from 20/100 become 20/20, and the left eye previous to the fitting only 4-meter finger counting and uncorrected with the glasses, but it is improved become to 20/100. And this is the last case from me. 26-year-old man has a history of penetrating injury 7 months before to the clinic. After the operation, the patient have a complaint about double and distorted vision. As we see here, we can see there is IOL capture and also very high astigmatism in the corneal topography, more than 11 dioptry. But the patient refused to do the IOL reposition or IOL exchange. So we hope we do the first optical correction for helping the patient, and we fit with the GP lens with base curve 7.9, the power only a quarter dioptry, minus quarter dioptry, and surprisingly the visual acuity become 1.0 and no double and distorted vision. As we see here, although the GP lens are rather to inferior, move to the inferior, but the visual acuity is quite good. And we see here there is a dumbbell shape appearance because the very high astigmatism. So as a conclusion, advance in lens material technology and design have enabled rigid gas permeable lens to improve quality of vision, durability of contact lens material, and compliance in contact lens practice. In some cases of poor corneal optics, rigid gas permeable lens may be the only optical solution. For successful RGP fitting, we have to understand the lens design and the correlation about the lens with the palpebra, with the gravity, and the ocular surface itself. Thank you. That's all my presentation. I hope you enjoy my presentation. Thank you.
Thank you, Dr. Fatima, for your great presentation about how the RGP lens shape the future of the contact lens. For the all participants, before we proceed to the last two presentations, we will have commercial break and continue the presentation afterward. So now we will continue with our presentation. Our next speaker is Dr. Tri Rahayu from DEC Eye Hospital. Dr. Tri Rahayu will present the topic of the Ortho-k beyond correcting vision. Please allow me to read her profile. Dr. Tri Rahayu graduated from Department of Ophthalmology, Universitas Indonesia. She did the fellowship at Cataract and Refractive Surgery at DEC Eye Hospital and also International Association of Contact Lens Educator. She is the president of Indonesian Refraction and Vision Optimization Society. She is also the member of International Association of Contact Lens Educator, member of Asia Dry Eye Society, delegate for Asia Dry Eye Society Summit 2019, Asia Pacific Ophthalmic Trauma Society, and also Indonesian Ophthalmologists Association. Dr. Tri Rahayu, please begin your presentation. The time is now yours.
Thank you very much, Dr. Manda, for the introduction. Good afternoon, everybody, and also, of course, Prof. Susuka. Hi, nice to see you again here. Thank you very much for always supporting our program in here in Indonesia, especially in Contact Lens Society, and also the GEC Contact Lens webinar today. So my talk today is about the Ortho-k beyond correcting vision. So myopia is a global public health now. We all realize that the myopia prevalence is increasing both in developing and developed country. It is estimated that by 2050 years, the myopia prevalence will be doubled. So the myopia prevalence will be about 50% among the people globally. And the highest prevalence is here in our region. It is in Asia's countries. Yeah, and myopia, especially high myopia, is related or associated with the high prevalence of ocular health impact. It is stated that in myopic person, the prevalence of primary open-angle glaucoma, myopic maculopathy, posterior subcapsular cataract, and retinal detachment are higher rather than a non-myopic person. So for that reason, the myopia should be prevented and controlled. Other thing is that the myopic children like that, it could be disturbed by using the spectacles for their activities such as ballet here, dancing, and also for playing football and other activities. So, other thing that the many specific occupation like firefighter or policeman or other hobbies like dancing, traditional dancing. Here is Saman traditional dance that need a lot of activities, a lot of movement and speed movement. So it is very disturbed if they are using the spectacles. Also for doing sport like swimming and other outdoor activity sport will be disturbed by using the spectacle. So in that such a condition, Ortho-k have an important role because Ortho-k can correct myopia and also can prevent myopia progression. So what is the orthokeratology? Orthokeratology is the use of specially designed and fitted contact lens, usually it is a rigid one, to temporarily reshape the cornea to improve the vision. So specific reverse geometry design of rigid cast permeable contact lens that was worn at night during the sleep, it will flatten the cornea, and while it is removed in the morning, the cornea still in the flatter shape. So in this reshaping of the cornea can correct the vision of the myopic patient. Then who is the Ortho-k candidate? There is not only the children who have myopia can use this and can get benefit for using this Ortho-k, but also everyone at any age with short-sighted or myopia can have the benefit for using the Ortho-k. The purpose of using the orthokeratology is to be free of spectacles and contact lens during the day. And also we can prevent the myopia progression. So then why Ortho-k can prevent the myopia progression? The progression of the myopia is believed because of the hyperopic defocus that can happen or occur while the myopic patient correcting with the spectacles or conventional contact lens. Orthokeratology that reshape the cornea, that make the cornea become flattened in the central and steepen in the periphery, it could make the defocus become myopic defocus, not hyperopic defocus. So that's why the myopia can be corrected, because hyperopic defocus can give signal to scleral growth to be more longer. So this is the effect of the overnight orthokeratology to the cornea and the refraction. It can reduce the myopia by central corneal epithelial thinning, and the mid-peripheral epithelial will be thickened, and the stromal also. So in this condition, they will leave myopic in the peripheral refractive errors, and it is corrected in the central of the cornea. The cornea become oblate like this, and the defocus will be myopic like this. Then what is the design of this Ortho-k? The Ortho-k have a 5 transitional zone. The central part of the Ortho-k is an optic zone, the part of the flat base curve. And then there is a reverse curve. It is steep rather than the flattest central part. And this is an alignment curve. The alignment curve could be 1 or 2 curve. And then the outermost is the peripheral curve. So this is another picture of the Ortho-k design. This is the base curve that is the flattest, and then reverse curve, alignment curve, and peripheral curve. So for fitting, we will use fluorescein to evaluate the fitting. The optical zone should be the flattest, so it is the dark picture of the central part of the cornea, and then the green picture in the reverse curve, and it is aligned, so it is black again, and let's add lift also must have a proportional or enough lift in the peripheral. So how is the procedure of fitting the Ortho-k? Step 1, like other fitting procedure, we must select the candidate who is suitable with the Ortho-k using. Usually it is the children with the myopia progression will give benefit for this, so it is the candidate. And who else that want to be free of glass spectacle should be a candidate. But we must rule out there is no corneal dystrophies such as keratoconus and other ocular disease. And also the one that do sports on like wear conventional contact lenses spectacle during the day, that do not like that. So it is the candidate. Also about the occupation. Above all that, the motivation is the important for selecting the candidate of Ortho-k. Step 2 is we must examine the patient. We must take the history of occupation, hobbies, visual demands, day-to-day activities, and then we perform complete refraction and ocular health examination, because the refraction will be the issue that we will overcome with this Ortho-k. We also do the topography, tear film analysis, don't forget it. And then we evaluate the anterior segment and pupil size, because it is also impact to the successful of using Ortho-k. The information required is about refraction, horizontal visible iris diameter, keratometric value, and also the topography. Step 3 is the lens selection. It is the first step of lens selection. We set the target power of the lens that we will use. For example, it is the refraction of -3 spherical with -1 cylinder, and the keratometric reading. So we choose for the tape from the table. This we will, the target power is -3, and then we take the keratometric reading, and we select the flattest patient keratometric reading. For this example, the patient have the flattest K 42 diopter and the steepest 43, so we select 42. If the patient flat K is exceed 45, then we just choose the 45 diopter. And we choose the lens diameter according to horizontal visible diameter with this normogram. Usually we use the diameter of Ortho-k 10.6 mm. And then after we select the lens initial, we insert the lens and evaluate the fitting with fluorescein. This is the example of small or no treatment zone, so it is not good because it will not give clear vision in the morning, because there is no enough flattening during using the Ortho-k during the night. It is the example of decentered lens, and the minimal edge lift is the sign of the too tight fitting. So it is not recommended to using. So the ideal fluorescent pattern is enough flattening in the central, so it looks black, and enough reciprocal or reserved curve, and then enough aligned curve, and enough edge lift. If we have it, then we can dispense the lens. Yeah. So there is any software for fitting this contact lens. It is Easy Fit software. We just input the data to the software about refraction and corneal topography. So the software will automatically calculate the Ortho-k parameters. This software also helps troubleshooting and improves lens fitting. So we only input the topography, the refraction, and horizontal visible iris diameter, then this software will calculate. So after we dispense the Ortho-k lens, we must do the follow-up. The follow-up visit will be the first follow-up is in early morning after first visit. It is one night using, then tomorrow we will see the patient. And then in 3 weeks, 2 months, 3 months, and 6 months. During the follow-up examination, we measure the uncorrected vision and best corrected vision, the manifest refraction that's still there, and we should do slit lamp examination to look for is there any fluorescein staining or not. And then we also take the corneal topography every each visit to look the flattening of the cornea and the centration of the lens while it is used. We have descriptive study about contact lens in our hospitals. During 2015 to 2019, we have 192 eyes fitted with Ortho-k. The age of the using the Ortho-k is about 13 years, and most of them are male. And then the spherical refraction about this. Time to need to reach 0 is about 60 days. And this is the uncorrected vision before using Ortho-k and after using the Ortho-k. And thanks God that this best corrected vision still good until 12 months after using the Ortho-k. The spherical equivalent is decreased a lot, and the axial length is increased just 0.20 mm per year. It is about the same with other studies. It's about like this. Yeah. And there is a case that they use the Ortho-k. This is the case, and it is because this 18 years old male have just a little cylindrical, and he want to join the army that could not be used spectacle. So I give him an Ortho-k, and after using a week, the refraction become plus 0.5. And then I advise to use only 5 days in a week. And after 1 month, he get refraction of 0 with the vision 2020. Thank you, Dr. Manda.
Thank you, Dr. Sri, for your presentation. It is so interesting to know about how the Ortho-k works to our eye. And now for the last presentation, we will have Dr. Damara from GEC Eye Hospital as our speaker. Dr. Damara will present the topic of the scleral lens, Let's Make It Possible. Allow me to read her profile. Dr. Damara graduated from Department of Ophthalmology, Universitas Indonesia. She already did fellowship in contact lens in GEC, scleral lens in Global Vision Rehabilitation Center, Miami, USA, and also at cornea, contact lens, and dry eye at Osaka University Hospital, Osaka, Japan. She is also the member of Indonesian Refraction and Vision Optimization Society, also the member of American Academy of Ophthalmology, and also she is a member of Tear Film and Ocular Survey Society, Asia Cornea Society, delegate for Hakone Dry Eye Club, International Association of Contact Lens Educator, British Contact Lens Association, and also Eye and Contact Lens Association. So for Dr. Damara, the time is now yours. Please begin your presentation.
Thank you, Dr. Manda, for the introduction. Good afternoon, fellow doctors, Prof. Shizuka, and participants. Today, I would like to present the topic of the scleral lens. Let's make it possible. Let me begin with cases. So first case, 63-year-old male, and he got PKP because of keratoconus. His cornea is very clear, but because of the high astigmatism, his vision does not seem to be good enough. At first, I tried corneal RGP for both eyes, and his vision became 0.6 with wearing lenses, but he complained of diplopia and photopsia. Second case, male 47 years old, he got double-headed pterygium surgery 5 years ago, and as you can see, the refraction difference between two eyes, and he felt the vision decrease progressively on the right eye. As for the third case, this patient had a history of trauma. His vision is only 2 meters finger counting. Please note that the orthograph examination seemed to be normal. And the last case, female doctor diagnosed with Stevens-Johnson syndrome. She complained of blurry sight, pain, and mucus overproduction. What could we do for these patients? And I couldn't have any answer until scleral lens appeared. But scleral lens could be just one of the options for these patients. So let me introduce some about scleral lens. Scleral lens is a large diameter RGP lenses made of high decay material. Scleral lens is filled with preservative-free saline, so the cornea is constantly bathed in fluid. The lens is designed to fold over the cornea instead of touching the cornea, so it does not compromise the integrity of the corneal surface. They provide optical advantages of RGP lenses, which means we can correct astigmatism very well, and it provides comfortness like soft lens, so patients feel very comfortable while wearing lens. There's confusion regarding terminology to describe scleral lens. But technically, any contact lens that extends beyond the limbus could be considered as scleral lens. The main difference in scleral lens and RGP, beside the size, is that the RGP lens is touching the cornea, while scleral lens is not. And also, RGP creates a movement, so patients sometimes feel uncomfortable. For the base curve, diameter, and power, the scleral lens have very, very high range. If you compare three types of lenses, scleral lens, RGP, and soft lens, initial comfort of scleral lens is similar with soft lens, but long-term comfort, scleral lens is superior, but it has a little bit difficulties of the handling. As for the quality of vision, especially for irregular corneas, scleral lens is superior than others. Indications of scleral lens are widening, from at first only irregular cornea such as keratoconus, keratoglobus, and PMD, into secondary corneal ectasia or postsurgical corneas. Now even normal corneas recently for presbyopia, and also comfort and ocular protection for severe dry eye, such as incomplete lid closure also, patients with grave disease and corneal scar or lag of thalamus. And let me show you the anatomy of the scleral lens. It is composed of three zones: optic zone here from here, and transitional zone here, and landing zone or haptic zone. Optic zone has to avoid bearing. It has to be flowed over the cornea, so it cannot touching the cornea. Transitional zone has to touch the conjunctiva very softly, and landing zone is over here. We can control optic zone by changing the base curve, and transitional zone we can changing by changing the diameter, and haptic zone by changing the edge lift. This is the fitting process. Firstly, about the optic zone. optic zone has to clear the steepest point of cornea, here, here, and here. You can see the fluorescein field clearance fluid in here. And if you see very detailed, you can see the lens thickness in here. So we can check optical zone by using the 45 degrees oblique slit lamp or using OCT anterior. Clearance means this space between anterior surface of the cornea and posterior surface of the scleral lens. And the desired clearance has to be between 200 to 150 microns because the lens goes down as times goes up. I usually use the 30 minutes finding. But if you don't have OCT, it's okay. OCT makes the fitting process easier. However, it's not necessary. We can always estimate the fluorescein under the corneal chamber. And we can, if we have pachymetry, that's better. But if you don't have pachymetry, we can estimate the corneal thickness about 540 microns. And this clearance, we want to aim about 2/3 or half the corneal thickness. This is the OCT image of not enough corneal clearance, or the liquid reservoir is not enough. We can see this is the cornea touching the posterior surface of the lens. And this is not enough clearance, only about 50 microns. And this is the OCT image of too much clearance. Secondly, about transitional zone. Transitional zone should not touch the limbus. We can see here the staining of also in the limbus, or you can see also in the OCT anterior. Lastly, the landing zone. The landing zone can be checked by observing the vascular compression pattern. Let's go back to the cases I already presented. The first case, 60-year-old male, and he get PKP because of keratoconus. And you can see the protruded cornea over here. And the refraction also showed very high astigmatism. At first, we tried corneal RGP. The vision improved, but the patient feel diplopia and photopsia. The photography showed very irregular cornea. With this kind of case, it's very hard to determine the base curve. So I just tried the steepest base curve trial lens we have, base curve of 6.25. The visual acuity of the patients becomes 6/6, but fitting nipple cone or monster cone like this is very challenging. We can confirm from the OCT that only little clearance over here, and over here there's no clearance, so the anterior cornea is touching the lens. So for this patient, we'll calculate by manual to get the steeper base curve. This is the clearance that we want to achieve. This is overview of the entire eye, and you can see the general diffuse fluorescent pattern. It looks pretty even and symmetrical over the entire cornea, limbus, and sclera. Corneal vaulting reduces the risk of corneal scarring, so because the lens is not touching the cornea, and the patient is very happy. This is the point spread function, the optical quality of the vision. We can see this is the before scleral lens and this is after scleral lens. So we can see that image quality is improved and also the aberration also decrease. Second case, the patient, the pterygiumplasty patient. We can see that granuloma over here and also over here, a cicatrix of the scar of the cornea. And the patient's also complaining of blurry vision. From the pentacam, we can see it is consistent with the irregular cornea over here and the scar over here. And I tried fitted with corneal RGP, but the vision remained the same, and the patient complained of distorted vision. So we tried fitting him with the scleral lens, and the vision become 6/6. But because of the granuloma, we concerned that it could begin the inflammation. So we try to design a notch on the scleral lens like this, so it's not touching the granuloma. We can see the granuloma over here in the OCT, and we hope to minimize the inflammation because of the notching. And we can always use a notch in the patient with maybe conjunctival elevated and also glaucoma transplant. Third case, the trauma man. The patient the visual acuity only 2 meters finger counting, uncorrected. Please note that the autoref of this patient is seem to be normal. And the patient underwent fundus photography and showed no abnormality. Macular OCT also showed no abnormality, and then visual field test performed. And this patient referred to our neuro-ophthalmologist, and full field ERG and pattern and flash VEP then performed on this patient. And the results showed no dysfunction of visual pathway. Retinometry also showed zero point 0.3, and the DX laser also performed. Many diagnostic examination has already performed on this patient, but then referred to me because my colleagues did not lose hope on this patient and did not give up on this patient. And we can see a little bit irregularity on the cornea, even though the outer examination is seemed to be normal. This patient once diagnosed with unexplainable visual loss, but then when we tried the scleral lens, fortunately, the patient can see very well. The vision is really very excellent, and the patient is very happy. And the last case, the female doctor with Steven Johnson syndrome, she complained of decreased vision, pain, and mucus overproduction. She previously already went to ophthalmologist, or other ophthalmologist with treatment of the Steven Johnson syndrome and dry eye. And even though the vision is become 20/20, it's never been better, but this patient complained of mucus and also build up more mucus, even though she complained the mucus is already there the whole time, but after wearing the lens, it's more pronounced. And what to do for Steven Johnson syndrome patients, sometimes preservative can cause irritation. So that is why we recommend to use the non-preserved one. And also treat the dry eye. The potential cause can be excessive tear exchange, so the mucus can accumulate. So we can always tighten the scleral lens or steepening the landing zone. And I try to change the material of the lens to plasma purified proprietary. And the patient's vision remained 20/20, and she could wear the lens for up to 12 hours. In keratoconus, the corneal irregularity can disrupt the vision. In early stage, we can still manage with RGP, but with advanced stage, it's very challenging because the lens sometimes decentered and also discomfort for the patients. The most patient were encouraged to undergo corneal collagen cross-linking that can slower the progression of the disease, and the majority will undergo with corneal transplant surgery. But before that, we can consider scleral lens. This could delay and prevent invasive procedure. There's one report about keratoplasty. There was a long-term outcome for keratoconus. The mean duration is about 5 years. It's a very long time, and I think it's very believable data. And they showed that the visual acuity of scleral lens can become zero point 0.8, very excellent. And they said that scleral lens could be the option for the patient after keratoplasty for visual rehabilitation and to prevent or delay further surgical involvement. As for the dry eye report, this author included Steven Johnson syndrome, 22 eyes, Sjogren syndrome, and also graft versus host disease and dry eye after LASIK. They got very excellent visual acuity, which the visual acuity improved, and also decrease in tear osmolarity. So they concluded that improvement in dry eye symptoms and quality of life. They recommended scleral lens. So, as for conclusion, the use of scleral lens was an effective option for patients with corneal irregularity and ocular surface disorders. They provide both successful visual outcomes and comfort. Their use may delay or prevent further surgical involvement. They can be used also after following surgical intervention. Thank you for your time and attention.
Thank you, Dr. Damara, for your inspiring presentation in scleral lens practice. So now we already finished our first session. So we will proceed to our second session, which is the Q&A session. I would like to remind you all again, please fill in the polling at the end of the webinar today. And the first question, I believe, goes to Professor Shizuka. Good afternoon, Professor Shizuka. There's a question about the prevalence of acanthamoeba infection on the cornea in the contact lens wearer.
Thank you for the question. Unfortunately, I don't have the exact number, Definitely, we sometimes have academic keratitis with contact lens wear. But in Japan, actually, I think in my impression, the number of the infected cases are a little bit decreasing because we actually educate the patient actually to the proper use of contact lens. So how about a situation in Indonesia?
Yes. In
So,
Indonesia, the prevalence.
Indonesia, yes.
Yes. Is there, Dr. Trira Hayu, maybe? Do you have any expertise about the prevalence of acanthamoeba infection in cornea in contact lens user in Indonesia, doctor?
According to my experience, there is not a lot of acanthamoeba infection, but I'm so sorry also that I have no exact number. The infection that we much more face it is about the bacterial keratitis. So it is gram positive and gram negative like this. Not so much acanthamoeba, or maybe we not so aware about that. I don't know exactly.
Thank you, Dr. Sri. And then the second question is to Dr. Vidyapati. It is about the Ortho-k, doctor. Is it the long-term effect of Ortho-k can slow the progression of myopia or even minimize the refraction error as it alters the corneal curvature? Thank you very much.
This question has actually to be answered by Dr. Vera Hayu because she has the records of follow-up of patient. But it is temporary. It will temporarily be subject to evaluation. Dr. Sri.
Yes, Dr. Fit, may I answer Dr. Andrew Logan question? So the Ortho-k, like my presentation before, can halt the progression of the myopia because the Ortho-k use is make the cornea become oblate. So it is overcome the hyperopic defocus. So the defocus will be myopic. With the myopic defocus on the retina, the signaling of the scleral growth will halt the progression or the elongation of the axial length. So it halt the myopia progression. So
it can halt the myopia progression, doctor, as you already presented. Thank you. And then, so this is the next question for Dr. Tri. Can Ortho-k actually treat astigmatism? And if it can correct it, the maximum astigmatism power it can treat, how much is it? And how many? And can it treat irregular astigmatism? Thank you.
Yes, for regular astigmatism, we still can use Ortho-k for 1.50 diopter of against the rule astigmatism, and up to 2.5 diopter of with the rule astigmatism. But exceed that, it will not totally corrected.
And also for Ortho-k also is do we need to do axial length examination for a routine evaluation in Ortho-k patient, Dr. Tri?
Yes, of course. For measuring the refraction, we cannot measure refraction by doing subjective refraction because after using the Ortho-k, the cornea still in the flat shape, so we cannot measure the refraction. So for measure or predict the myopia progression, we only use the data of axial length. So we know that we all know that the increasing of axial length by 0.3 is about increasing the myopia 1 diopter. So we can calculate the about the increasing in myopia by calculating the increasing of axial length. So it is mandatory to do axial length measurement during the follow-up of Ortho-k wearing.
And
Are you
how
agreed, Prof. Susuka? Maybe do you have any other
do you have any other opinion, Prof?
opinion, Prof?
Okay, yes. Thank you. Thank you for the update from your country. So actually, all keratology lens are not so far. I don't have any clinical experience of prescribing Ortho-k, so I actually learn a lot from you. So actually, I have a question. One question. So
Yes.
right now, so actually we have difficulties in associated with coronavirus. So do you have some kind of different difficult situation? So actually follow up with Ortho-k lens.
Yes, for not only Ortho-k, but for the all contact lens practice, we do the other with the protocol. We change the standard operating procedure for fitting the contact lens. So we before fitting the contact lens, we disinfect the eyes with the diluted povidone or solujot, and we after each of fitting, we disinfect the contact lens trials with the hydrogen peroxide based solution.
So, my one more question. So, are you right now? Are you allowed to feed the contact lens to the new patient? New patient.
We what is it? Membatasi. We limit it and not. If it is so necessary, then we do it. But if we can postpone it, we can postpone it. We will postpone it.
Okay, thank you.
Thank you, Professor and Dr. Chi. Also, this is still about the Ortho-k. What if we don't have any topographer, Dr. Tri? How can do we still can prescribe an Ortho-k lens, or is it a must to have a corneal topography? Thank you.
I think it is better that we have corneal topography for practicing the Ortho-k, because we could only evaluate the centration of the Ortho-k with the evaluating the flattening of the cornea from the corneal topography. But for fitting, if we have an topography cornea, we still can use the data of keratometric value and do the fluorescein evaluation for the trial lens fitting. But I'm not recommended you to do this fitting if we don't have any corneal topography. I think that, Dr. Manda.
And the next question is to Dr. Fatima. For the patient age around 45 with myopia -5 and astigmatism power is 3, what do you think the best therapy for this patient, and do we still can consider RGP for this case? Thank you.
Yes, thank you, Dr. Amanda. We can consider for the high astigmatism using the RGP because in my experience, the high astigmatism can get a better vision using the RGP. But we have to consider that when we prescribe the contact lens, the need of convergence is more. So in a patient over 40, will need convergence more than the younger patient. And also maybe about the dry eye condition, as we know that the patient over 40 is high risk for dry eye. So you have to make sure or to screening the patient that the tear film is good, and there is no dry eye condition. Thank you.
And this is the last question to Dr. Damara. In your presentation, the scleral lens has many benefits as it can provide optical advantages of RGP lenses and the comfort of soft contact lens. Can you share with us your experience encountering the challenges and limitations in using the scleral lens? Thank you, Dr. Damara.
Oh, ada suaranya.
Please unmute, Dr. Dere.
Sorry. Okay, can you hear me?
Yes.
Yes. Okay, the challenging of the scleral lens usually more into the fitting process. So it's different from RGP and soft lenses. Scleral lens need fitting process longer, and sometimes the patients has to wait for a long time because we have to do the fitting and then the OCT examination, also changing the base curve, especially if the cornea of the patient is very irregular, then it's harder to find the right base curve and the right sagittal depth for the patient. I think they say that after about 10 cases, if you practice with fitting scleral lens, after that, then you can be good at it. So I think it's gonna be challenging if the patients has severe keratoconus or post graft or post surgical cornea. Beside that, I think it could be manageable. Did I answer the question, Dr. Manda? Yeah, hopefully. Yeah.
Dr. Manda, unmute.
Sorry. Okay, I think we already finished our second session, the Q&A session. Is there anything that the panelists or the speaker want to add? Okay, I think that's all. So now we will have our polling here. Can you show me the polling? For all the attendee, please fill out the polling that we already prepared so we can improve our webinar. Okay. Okay, so dear participant, I like to still, last but not least, we still have a tomorrow session of webinar. So tomorrow webinar is from the GEC Ophthalmic Trauma Service, tomorrow night to be precise, which is the fourth Asia Pacific Ophthalmic Society webinar with the topic of overcoming the challenges in ophthalmic trauma. We will have so many international and national respected speakers. So we hope to see you all tomorrow night. Okay, so dear participant, we now reach the end of today's session. We are very sorry if we were unable to answer all the questions due to our limited time, but hopefully today's lecture will help us improve our knowledge and perspective to manage the patient of contact lens. I would like to thank you all the participants who joined this GEC contact lens webinar. Thank you for the GEC team for making this webinar possible, and also PT Cendo and SIP company for supporting this webinar. Our biggest appreciation to our international speaker, Professor Sisukako. Thank you, Professor Sisuka. And
Terima
also,
kasih.
yeah, sama-sama, Prof. And all of our respected speaker from GEC Eye Hospital. Thank you for sharing your time and expertise to all of us. I'm Manda, your host today. Good afternoon, stay safe, healthy, and thank you.